Welcome to the MRCpology channel for a quick review and understanding of the topic. Imagine a young patient in clinic with multiple Café-au-lait macules, axillary freckling, soft skin nodules, and a history of learning difficulty. The MRCP question is not just, what is the diagnosis? The better question is, which tumor suppressor pathway has failed, and which complications must not be missed? Neurofibromatosis refers to a group of autosomal-dominant tumor-predisposition syndromes. The underlying theme is loss of tumor suppressor control in tissues derived from the neural-crest. That is why the clinical features can involve nerves, skin pigment cells, bone, optic pathways, and the central nervous system. To keep the topic organized, think of three related conditions: NF1, NF2-related schwannomatosis, and schwannomatosis. They overlap because they all involve nerve sheath tumors, but the clinical clues are different. In NF1, the mutation reduces neurofibromin. Neurofibromin normally switches off RAS. So when neurofibromin is lost, the brake on RAS is removed. RAS remains active, MAPK and PI3K signaling increase, and cells are pushed towards excess growth. That mechanism explains the clinical picture. In Schwann cells, excess growth produces neurofibromas. In melanocytes, abnormal signaling increases melanin deposition, producing Café-au-lait macules and axillary or inguinal freckling. In bone and the central nervous system, dysregulated growth contributes to skeletal dysplasia, gliomas, and learning difficulties. Clinically, NF1 is the condition of Café-au-lait macules, skin fold freckling, neurofibromas, Lisch nodules, optic pathway glioma, skeletal problems, and neurodevelopmental difficulty. Café-au-lait macules are usually the first clue. Axillary and inguinal freckling are particularly useful because they are more specific than Café-au-lait macules alone. Cutaneous and subcutaneous neurofibromas are benign Schwann cell tumors presenting as soft skin nodules. Plexiform neurofibromas are more important clinically because they represent diffuse nerve sheath overgrowth. They can cause disfigurement, compress nerves, produce neurological deficits, and carry a risk of malignant transformation. Lisch nodules are iris hamartomas. They are usually asymptomatic, so they are more useful diagnostically than clinically. Optic pathway gliomas may cause visual loss or proptosis, and if the hypothalamus is involved, they can present with precocious puberty. Skeletal involvement may cause scoliosis, tibial bowing, or pseudoarthrosis. Learning difficulties and ADHD are also common and should not be overlooked. Now contrast this with NF2-related schwannomatosis. Here, the mutation affects NF2, producing defective merlin. Merlin normally helps cells stop growing when they become crowded. In other words, it contributes to contact inhibition. When merlin is lost, that contact inhibition fails and tumors form. The classic clue is bilateral vestibular schwannomas. These compress cranial nerve vate, causing hearing loss, tinnitus, and imbalance. NF2-related schwannomatosis is also associated with other schwannomas, meningiomas, and ependymomas. So a patient may present not only with auditory symptoms, but also with focal neurological deficits or raised intracranial pressure depending on tumor location. Schwannomatosis is slightly different again. It is usually related to SMARCB1 or LZTR1 mutations, both tumor suppressor genes affecting Schwann cell control. Loss of that control leads to multiple schwannomas. The main clinical feature is pain from multiple schwannomas. The important distinction is that bilateral vestibular schwannomas are usually absent. MRCP trap: do not group all schwannomas together. NF2-related schwannomatosis classically gives bilateral vestibular schwannomas. Schwannomatosis gives multiple painful schwannomas, usually without bilateral vestibular involvement. NF1 gives pigmentary changes, neurofibromas, optic pathway glioma, Lisch nodules, skeletal dysplasia, and learning difficulty. Diagnosis is often clinical, based on characteristic features and family history. Genetic testing is helpful when the diagnosis is uncertain, and it also supports cascade testing in relatives. MRI is not needed for every skin lesion, but it is important when symptoms suggest optic pathway disease, vestibular schwannoma, spinal lesions, or intracranial tumors. Management is not curative. The principle is surveillance plus treatment of complications. In children with NF1, ophthalmology review is important because optic pathway gliomas can threaten vision. Blood pressure should be monitored because hypertension and vascular complications may occur. Neurodevelopmental support matters because learning difficulty and ADHD can affect education and quality of life. MRI is used for symptomatic lesions rather than as a blanket investigation for everything. Surgery and radiotherapy are considered selectively, depending on tumor type, site, symptoms, and risk. For inoperable symptomatic plexiform neurofibromas, MEK inhibitors are now an important targeted treatment option because they act downstream in the overactive RAS-MAPK pathway. If you remember one thing, remember this. NF1 is mainly neurofibromin loss, RAS overactivity, pigmentary features, neurofibromas, optic glioma, and skeletal or learning problems. NF2-related schwannomatosis is merlin loss with bilateral vestibular schwannomas. Schwannomatosis is multiple painful schwannomas, usually without bilateral vestibular schwannomas. Quick recall. A teenager has Café-au-lait macules, axillary freckling, soft cutaneous nodules, scoliosis, and learning difficulty. Which tumor suppressor protein is reduced, and which signaling pathway becomes overactive? The answer is reduced neurofibromin, causing persistent RAS activation with increased MAPK and PI3K signaling. An adult presents with progressive bilateral hearing loss, tinnitus, and imbalance. An MRI shows bilateral vestibular schwannomas. Which condition is most likely, and what is the key distinction from schwannomatosis? The answer is NF2-related schwannomatosis. The key distinction is that bilateral vestibular schwannomas are typical of NF2-related schwannomatosis, whereas schwannomatosis usually causes multiple painful schwannomas without bilateral vestibular involvement. Do subscribe to the channel for further videos.